Hello everyone, and welcome to our cardiovascular imaging conference from the DeBakey Heart and Vascular Center. I'm Dr. Zoghbi, Chief of Cardiology here, and it's a pleasure to give these presentations today. Actually, we have three of our faculty who are giving the presentations on myocardial viability. So we want to be as comprehensive as possible, putting it together in the context of an important but maybe less crucial nowadays, and the questions are different about myocardial viability, but I think it's very important for people early in their career that whenever you see a depressed heart, particularly in the setting of ischemic heart disease, yes, our medical therapy has improved so much, but there is actually viability of that myocardium that can be detected clinically. Yeah, that can be detected either clinically or with our imaging modalities to try. Better? Yeah, that's right. Okay. Adjusting the microphone. I like that. All right. So what do we talk about myocardial viability? And this is, I would say, close to 40 years now concept that in the early days where we didn't have too many imaging modalities, and you go to the catheterization laboratory and you do revascularizations with bypass as opposed to other modalities, that ventricular function could improve. And the late Dr. Rahimtullah certainly popularized that concept of myocardial hibernation as opposed to stunning. You need to know that myocardium can be stunned, and most of the early investigations were done here by Dr. Roberto Bolli when he was here with us in animal models where you have repetitive ischemia. And most likely hibernation, which is the chronic LV dysfunction in the setting of ischemic heart disease, significant ischemia, heart disease, could be a result of repetitive stunning, because when you image patients, they're at rest, they go walk around, their heart rate is higher, they get more ischemia, etc., etc. And the beauty of it is that some of these patients actually, after revascularization, their ventricular function improves, either regionally or globally. And I think we have to keep that in mind, even in the setting of significant improvement in our medical therapy for heart failure. So since this is an imaging conference, where do all these imaging modalities fit in our detection and good prediction of recovery of function after revascularization? Remember, the setting is ischemic heart disease and ventricular dysfunction. So we can go from the EKG, which is still important, to echocardiography, contrast, PET, nuclear, CT, as well as MRI, and we're going to try to cover all these areas rather quickly, but at least to give you a comprehensive view. So when you think of dysfunction of the myocardium in the setting of ischemic heart disease, these are the scenarios that you can think of graphically from a schematic point of view. One, the left side, is that the myocardium is still quite viable. You may have some decrease in capillaries, but if you revascularize, this heart will improve significantly. To a mixture of some ischemic or scarred myocardium, as well as some stunning of the myocardium, or hibernation, if you will, or a completed infarction where no matter what you did really in that area of dysfunction, of scarring, that you may not have any more significant viability nor recovery of function after revascularization. So what are the questions that we're asking for nowadays in the current era? Is you want to identify patients that would benefit from revascularization, particularly in the setting where they're not symptomatic, they don't have either heart failure or angina, etc. Predict recovery of regional and global ventricular function after revascularization. And to me, the most important one nowadays is, in patients with advanced heart failure, decide on the management, whether revascularization, it looks like my voice comes and goes, and it's not have nothing to do with my voice. Help decide management, revascularization versus a advanced therapy of VAD or transplantation. I think nowadays this is the most important one, and the reason for it is with multi PCI procedures. You could do that nowadays for revascularization, so it's less risky. Even at bypass, if you're going to go to bypass, you could do that off pump to reduce the issues that could happen. So the last one is probably the most important one, but I know it's important to go through the exercise of what you could do nowadays to look at viability. And these are the indicators of viability. If somebody has angina, you got viable myocardium. At least may not be global, but lack of Q waves. If you have Q waves, you cannot tell, but lack of Q waves tells you about viability. Hypokinesis as opposed to akinesis. Contractile reserve, we'll talk about it with echocardiography. Radionuclide uptake. Usually we do that with thallium and the usual SPECT, but PET I think is probably the gold standard regarding that for viability. Inducible ischemia, so if you have ischemia that you're inducing with wall motion or perfusion, and no or minimal delayed enhancement on gadolinium with CMR. So these are the various modalities that you have, and you have to put it together as a clinician to see which ones do you need. Do you really need all of them? Most likely not. So you have to decide one way or another, how do you do this? And you need to know the anatomy, the coronary anatomy, whether you can revascularize or not. So this is old data, and actually most of the data that you're going to see is, it's not the most recent because, we know quite a bit about the field. This is data from Yankee Young many years ago from our institution looking at how specific. Look at the red specificity. If you have no Q waves, the specificity of viability is very high. But if you have Q waves, you really cannot tell, and therefore you need more data. And for echocardiography, we use contractile reserve to see whether you still have some reserve in the myocardium. And if you have reserve, therefore you have viability. Okay? So the modality that is used early on in the cath lab, people used isuprel and other things, but nowadays you use echo. Notice that we emphasize the lower doses of dobutamine in addition to the high doses to tell you more about viability, because there is a balance between ischemia induction and contractile reserve. And this is such an example of a patient who has large inferior infarct that you could see there with some viability, and you could see that 5 and 10 mics as well as max that we do. There's no single dose of dobutamine that will give you where you have an improvement in function, and this is dosimetry, if you will, from our early data from Imran Afridi when he was with us many years ago, and he's in the Dallas area. So at 7.5, at 5 you can't detect all of them. At 7.5 to 10, you're going to detect the vast majority of these individuals. So a combination of maybe a 5.75 or 5 and a 10 in addition to the max dose may tell you about where there is contractile reserve, yes or no. And if you use dobutamine or any inotropic agents, what do you see? The most specific for viability is a biphasic response, called biphasic because in the lower doses you have improvement, and a little higher dose you have ischemia. And therefore I have contractile reserve and I have ischemia, and therefore if I revascularize conceivably, I will improve function. The others have no change. Sustained improvement is an interesting one, meaning I'm not causing ischemia. I improve the heart. It's almost like a cardiomyopathic response. So therefore, in those areas, if this is only what you see, the likelihood of recovery of function is low, because if I revascularize this heart, I didn't have ischemia to start with, and therefore, most likely, I'm not going to improve much. There's a small area where the only thing that you could see is just worsening function. They have no reserve whatsoever, and this is also important because you have a lot of ischemia in these individuals, right? Predictive value, in green, recovery of function, the highest predictive value of dobutamine echo is a biphasic response at 72%. Worsening, just pure worsening, pure ischemia without contractile reserve is lower, and the other, no change and no improvement, very little positivity to it. And this is a prediction of this is basically the summary of it. Now, if you require any improvement, you're more sensitive than specific. If you want to be very specific, you're going to require a biphasic response in these individuals. Few other things on echocardiography that come, almost grata, is thinness of the myocardium. Scarred myocardium is usually thin, although there are some data, and I know from Dr. Shah, before he joined our institution, that Actually, you still have viability, but the likelihood viability is low. So if I have a very thin myocardium, just like you see here, is scarred down, very thin, likelihood for recovery is rather low in these individuals. And we did in the early days. Jocelea Zweig was with us, and she's in Brazil nowadays, and compared in the same individual nuclear uptake with rest redistribution thallium versus hypokinesis and akinesis, and the thickness of the myocardium. As more and more dysfunction occurs, as less radionuclide uptake there is thinning of the myocardium. And interestingly enough, you probably know that with nuclear rest redistribution, 60% is usually the cutoff. It's about 6 millimeters of thickness of the myocardium. Below that, likelihood of recovery is rather low. Above that is higher, but you could use that in addition to echocardiography and dobutamine responses. So you can combine them together. And the last one is an end-diastolic wall thickness of greater than 6 millimeters with a DSE response. Gives you a decent predictive value for recovery. Okay? Minor few other things that we're not using anymore. We did a lot of work with them before. Perfusion with contrast echo. Bottom line for perfusion with contrast echo is very similar to rest redistribution thallium. These are data from our institution here. And there are tricks for perfusion in contrast. You have to use low MI. You can use destruction recovery. I'm not going to belabor that because we're not using it unless in experimental situations, because the other modalities have really taken over and much more reliable than this. But with contrast echo, you can look at amount of perfusion that is coming in. You could look at coronary blood flow when you destroy and recover the contrast. And basically, in a study that we did with Sarah Shimoni, she's now obviously faculty, a renowned faculty in Jerusalem, MCE qualitative, MCE quantitative is very similar to rest redistribution thallium. High sensitivity, lesser specific. So if you want more specific data, best is causing ischemia with some contractile reserve biphasic response with dobutamine echo. If you want more sensitive, less specific, a perfusion agent, not PET, a perfusion agent, be it contrast echo or SPECT, rest redistribution. Last is diastolic function. Interesting to me, I think is if you take a look at diastolic function, and we know that in diastolic function, looking at mitral inflow dynamics, that it is definitely very load dependent. But interestingly enough, at least in our data here, if you have a patient, like on the left side, with a compensated state, slow relaxation with low filling pressure, it imparts, conceivably, more viability in that individual as opposed to somebody who's very restrictive. And we've done some biopsy data here. Yonki Young is one of our physicians also. We did that quite a few years ago now. It's almost 20 plus years ago. And the more compensated state that you have, the more segments with viability that you have. And in these individuals, the ones who had a compensated state, which is group 1, had less fibrosis, had more contractile reserve, better change in EF afterwards, less ICU state, better New York Heart Association, and less need for transplantation. So in summary, for echocardiography, few things are important for you. One is, if you want to do a dobutamine echo for whatever reason, not necessarily for viability, but you have in that individual segments that are akinetic or hypokinetic, you could use that as part of your interpretation in addition to looking at ischemia. So if I have a contractile reserve with or without a biphasic response, it tells me something about viability of the myocardium. If I'm inducing ischemia, much more specific. Ischemia induction, right, convey a higher likelihood of recovery of function. So, if you're wondering whether should I revascularize an individual, yes or no, very specific. Myocardial thickness can help in the evaluation of viability. Threshold usually about 6 millimeters of thickness. Contrast echo improves the accuracy, and it's similar to nuclear perfusion. Nowadays, just because of heterogeneity, a little more complicated way of doing it, at least our center is not using it. Actually, the vast majority of centers are not. There are some centers, Dr. Tom Porter uses it and a few others, but we don't use it as much. But it's a great tool to do in the animal model to look at myocardial blood flow. So Dr. Al-Mallah, I think, will cover nuclear and PET with us on what the role is in the assessment of viability.
All right. After this great introduction by Dr. Zoghbi, let me take you to the nuclear techniques. But before that, I know that we can do viability, but we are all seeing a lot of decline in the number of viability studies that being ordered. And now they are more like a different indication or different approach to managing these patients. So for the fellows, I think when you see patients with heart failure, I'm going to start, this is viability in general, not only nuclear techniques. When would I order viability testing, or when does it add information? Usually if you have a young patient, you're probably going to give them the benefit of the doubt and try to revascularize them if there is obviously like favorable anatomy. Let's see what happened. Okay. If they are symptomatic, as we just heard, then this is like a great indication that their myocardium is viable. If there is obviously ischemia detection by whichever modality you want to use, that's also another indication that you don't need viability. What's going on here? And if they have higher left ventricular ejection fraction, most often, most of the viability studies were done primarily among patients with lower ejection fraction. So if they have higher ejection fraction, you technically most often don't need viability assessment. Obviously, if there is favorable coronary anatomy for revascularization, or where there is clear benefit of revascularization, like left main disease, you don't need to order viability for these patients. And finally, if there is no or limited comorbidity, these type of patients we tend to more assess them and clinically by ischemia assessment and clinical judgment rather than viability testing. Most often it's the opposite. When we see a patient for viability, it's a sick patient, elderly patient, multiple comorbidities, very low ejection fractions, multiple procedures, sometimes even 2 or 3 prior cabbages, and now they're going for the 4th or 5th cabbage and redo median sternotomy, and they want to know, is it worth the risk of the procedure? And this is the type of patients that we see in our testing for viability. Now this is kind of like applies to all imaging modalities. Let's go specifically for nuclear techniques. So how do these compare? Obviously for viability you have multiple options, and if you want to order which test, it very much depends on what's available in your institution. We're lucky here we have all tests that are being offered and done with high quality, but most often in the community the physicians are limited to 1 or 2 tests that they can use viability for, or sometimes they have to refer patients to other options. If you want the simple comparison, this comes from the meta-analysis, which you just heard from Dr. Zoghbi about specificity. The highest specific technique is Dobutamine echo, low-dose Dobutamine echo, specifically the bivasic response. This is the most specific. For sensitivity, it's primarily the nuclear techniques, and they assess viability in multiple ways. And if I'm to pick one of the nuclear techniques, it's going to be primarily PET for reasons I will show you later on. So in nuclear, how do we assess viability? We assess two things. Number one, we assess the sodium-potassium ATP channel or the cell membrane integrity using these different tracers. And this can be done by SPECT and PET, thallium, technetium, and potentially PET tracers like rubidium or ammonia. And we have by PET specifically another way to look at it, which is looking at the mitochondrial metabolism and trying to look for specifically metabolism of these hibernating myocardial cells. So with nuclear, specifically with PET, we have two modalities to look for this. Now in our center here, we kind of stopped doing SPECT viability about maybe now 5 or 6 years ago for reasons I will mention to you. But if you go out to practice, you will see that in the country, the most utilized viability test is SPECT imaging and stress echo. This is what's widely available. Now MRI and PET is increasing in utilization, but most studies that you see in the literature come from Dobutamine stress echo and from thallium but they are still highly tested on the boards. For the fellows, you're probably not going to see a clinical case. Maybe we do 1 or 2 a year, but let me review with you a little bit the protocols that we do. So thallium we use it because of its redistribution phenomena. So we inject thallium, it goes inside the cell, but then it goes outside the cell membrane because it's a potassium analog, so like potassium, and slowly diffuse to the area that's supplied by a tight stenosis. And if that cell is viable, then it will take that potassium and have it inside. So we use that, either we inject thallium, image the patient, and then we can re-image them again and re-image them again multiple times to try to see if that area that didn't get thallium in the beginning, is it getting thallium later on. And we can do it as rest-only imaging, or we can do it in combination with stress test. And these are some of the thallium images, how they look like. So you see here you will see a perfusion defect. Let me see. Okay, so here's my mouse. You see a large perfusion defect. When we image the patient after 4 hours, you start to see that this perfusion defect is getting smaller. So this means that the septum is viable. There is a small scar here in the inferior wall, which is viable, and what we see here is a combination of a scar and the hibernating myocardium. Initially, they were even bringing the patient 24 hours later and then just do another set of images, because sometimes thallium will take longer to redistribute. And what you see here, thallium has a half-life of 73 hours, so you can image the patient almost up to a week and still get images. But after 24 hours, you're not going to see much benefit. So that's for thallium. Now in the US, for the past 2 years, thallium is no more available. So even if you want to do thallium, you cannot do thallium. So we are stuck with another option with thallium, with SPECT, which is technetium. So technetium is widely available. It's the same agent as we do with our stress testing. So your new stress nuclear that we do on 409, that's the same agent that we do. The main difference between technetium and thallium is that technetium does not redistribute. So the redistribution phenomena is what we are using for thallium. Now we lost it with technetium. So what do we need to do? We want to do maximal vasodilation for these patients before we inject the dose. And how we do that? By giving them nitro. So for those of you, if you get a patient in 409 that you want to do viability by technetium, without nitro, it is not a good test. You need to add nitro. And these are the protocols, simple as you do a regular MPI, either rest or rest stress. There is no point in repeating testing because there is no redistribution with technetium. And this is a study that compared with or without nitro and looking at how much we are going to reclassify. And 40% of segments that were called non-viable without nitro turned out to be viable. And by the same tech agent, but by giving by giving nitro before doing the rest injection. So nitro, this is a common board question. Nitro is a must if you are doing technetium protocol for viability. Right now, we're only doing it if we cannot get the patient to MRI or PET, because we have these techniques. And one of the reasons we kind of use MRI and PET for viability is primarily because there are multiple studies that show the superiority of this technique of MRI and PET over technetium or thallium viability. And in this study, for example, 25% of segments that were called non-viable by thallium or technetium turned out to be viable by FTG PET. So you're going to be underestimating your viability burden by SPECT techniques. So what do we do with viability? With viability by PET, we assess the cell membrane like we did with SPECT, but now we add the metabolism part. So what do we mean by metabolism? We want to see that the Krebs cycle, or all these enzymes in the mitochondria that we studied in first year medical school, they are still functional. Now a cell that is ischemic or hibernating will use anaerobic metabolism, but still uses glucose. So for those of you who are eating now, your insulin level is going to go up. What happens to your heart? Your heart usually likes free fatty acid, but when your insulin goes up, your heart is going to switch to glucose. So that's exactly what we're going to do in the PET lab. So after we do the perfusion agent, we give them glucose, either oral or IV, and then once their glucose goes up, whether they're diabetic or not, we're going to start to push insulin. We want to make sure that these patients have enough insulin on board, so when we inject the radio-labeled glucose, these patients have enough insulin to make these hibernating myocytes take FDG and then go ahead and image them. So this is what I said. The hibernating myocytes love glucose, so we try to give them insulin so that they can take the glucose in. And the glucose is radio-labeled glucose, fluorodeoxyglucose. We label it with F18, and then we just go ahead. It goes inside the mitochondria and gets stuck there, so no glycolysis. And this is what we do. This is a protocol that our nurses do. So when you order a PET FTG, you cannot order it in the afternoon, because it's a procedure that's going to take at least 3 hours to 4 hours in the PET lab. Because it requires a nurse, they need to check the insulin every 15 minutes and then inject insulin every 15 minutes until we reach a sufficient amount of insulin on board, and then the serum glucose reaches 140, and then we go ahead and inject the glucose. And they have directions on how much insulin to give, and then they